Hello, I'm Dr. Chris Rogers. I'm a physical medicine and rehabilitation physician practicing in San Diego, California. I'd like to thank Dr. Ambach, Dr. Demers, and the Interventional Orthobiologic Foundation for this opportunity to speak with you today. Our topic will be on micro-fragmented adipose tissue, also known as MFAT, for the treatment of severe joint and tendon injuries. And I think you'll see that it's been a real game changer for those of us who practice non-surgical orthobiologics. Here are my disclosures. Now you may be wondering, like I was 7 years ago when I first learned about adipose tissue at a dinner with Dr. Arnie Kaplan and Dr. Carlo Tremolata, why adipose tissue would be useful for orthopedic conditions. Well, as you recall, it was Dr. Arnie Kaplan in 1991 who first characterized and named the mesenchymal stem cell. Later, it would be hypothesized that the MSC would be present in adipose tissue because, similar to the bone marrow tissue, adipose is derived from the embryonic mesoderm. Since then, it's been shown that the adipose MSC exhibits similar fibroblast-like morphology as the bone marrow MSC, and the adipose MSC has been shown to be able to differentiate into the different cell lineages associated with stem cells. Now, Dr. Zook and colleagues at my alma mater, UCLA, get the credit for first reporting on the adipose MSC in 2001, and they indicated correctly that the therapeutic potential of these multilineage stem cells would be enormous. But I would like to give credit to my friend, Dr. Ramon Yui, and his other colleagues, Dr. Katz, Hedrick, and Futrell, who actually were the first to report on this particular cell in 1999, and this was settled at a court hearing in 2009. Now, the MSCs derived from adipose and bone marrow are similar in morphology, as I told you, but they also have similar cell surface markers. These CD markers have been shown to be virtually 90 to 95% consistent across the different cell types, and that's true of the MSC derived from really any tissue source in the body. But the adipose MSC has certain attributes that make it highly desirable. For example, unlike the bone marrow MSC, there's been a minimal decline with age, although there is some in the adipose tissue. In addition, adipose tissue is abundant, particularly here in the United States, where most patients have enough. The lipoaspiration process that we use to harvest these cells has been shown to be safe and well tolerated. And the viability and number of these cells, as well as the type of cells that you obtain, can be influenced not only by patient factors, but also by the harvesting technique used and the processing technique used to further concentrate these cells. Now, the adipose tissue really is a heterogeneous collection of cells, 90% by volume made up of the mature adipocyte. However, also contains what's known as the vascular stromal portion of the adipose tissue, which contains both progenitor cells, such as the pericytes, endothelial progenitor cells, and preadipocytes, but also stem cells, such as the adipose stem cell and the hematopoietic stem cell. And then you can see the mature cells also found in adipose tissue include immune cells such as monocytes, macrophages, T regulatory cells and B cells, as well as fibroblasts, endothelial cells, and smooth muscle cells. And then in addition to these cells, we also have the structural components such as collagen and other complex proteins. Now, if you look at the published literature, the processed adipose tissue is explained with many different names. We are going to refer specifically to those studies that look at microfragmented adipose tissue, known as MFAT, but you can see it has been described in many different ways. If you then go on to isolate the cells using enzyme digestion, that's called stromal vascular fraction. And if those expanded stem cells are then used for your treatment, they go by many different names. The most common one, of course, is the adipose stem cell, or the ASC. Now, it's important to note that these different processing techniques will produce different biologic products. So you start with the lipoaspirate from the patient at the bedside. If it is emulsified and centrifuged, it's called nanofat. If you push it through larger filters and rinse it, it's called microfragmented adipose tissue. If you use enzyme digestion and centrifuge, that's called stromal vascular fraction. And again, if you culture those cells and expand them, that's the adipose stem cell. And those latter two products, the SVF and the ASC, require FDA approval because they exceed the minimal manipulation as stated by the FDA guidelines. And this brings us to the point, how many cells are actually in the biologic that you're offering your patient? We know that BMAC, microfragmented adipose tissues, SVF, contain stem cells, but these numbers pale in comparison to the cultured MSC products that start at 10 million and can go up to 100 or 200 million cells in a dose. So we need to be cautious that we don't translate the information from the stem cell research and apply that to BMAC or MFAT outcomes. And this is important for informing your patient. And we believe in truth in advertising. This is what the medical informed consent is all about. And we want to make sure we're truthful, that we're not selling stem cell stories when in reality we're dealing with something else. Now, there are a number of different FDA-approved devices available today in the United States and around the world to produce microfragmented adipose tissue, and some of them are shown here. I believe that each product will produce a different product, meaning that there'll be different cell counts, different viability, different mixture of cells, perhaps even different cytokine profile, and that is for future research to discover. So let's take a look at some of the preclinical data. Microfragmented adipose tissue developed from different FDA-approved devices has been characterized in the literature, most commonly with this one, where it's been shown that the adipose tissue is microfragmented to a size of about 250 to 650 microns. There's a reduction in the number of adipocytes, but the adipose tissue microstructure is preserved with an increased concentration in pericytes, a reduced concentration of the adventitial cells, which makes sense because you're eliminating the larger vessels from the adipose tissue. And then there's a high MSC number and multipotency observed. The cellular content was characterized in this study where healthy donors, average age 53 years, had their tissue processed with either the Arthrex Adipose or the Lipogem systems, and they were able to show very high MSC viability, as well as characterize how many pericytes, progenitors, and endothelial cells, as well as others, were in the final MFAT product. In addition, the secretome of these cells has been discovered, and it's interesting to note that there are high levels of interleukin-1 receptor antagonists, also known as IRAP, which, as you know, is an anti-inflammatory molecule. There are other anti-inflammatory cytokines and growth factors that have been characterized in the secretome, as well as immunomodulatory cytokines and growth factors. A number of exosomes and extracellular vesicle microRNA specific to cartilage protection and the M2 macrophage polarization process have been described in the lipoaspirate secretome. In addition, there's an increased expression of proteins which are specific to the protection against mechanical and oxidative stress. Now, one thing that I like about MFAT is when compared with leukocyte-rich PRP or bone marrow aspirate concentrate, there is a reduction in the blood cell component of the product. And so you can see on the left, we have what I like to call the mango smoothie, which is a yellow color, and you really have a very low red cell count, low leukocyte count, which may be advantageous for osteoarthritis. In studies where they co-cultured microfragmented adipose tissue with pathologic cartilage, it was shown that there was an increase in the production of glycosaminoglycan production, as well as proliferation of the chondrocytes. And in this study where explanted hips from patients who had undergone hip replacement, it showed that there was a repopulation of the areas that had damaged cartilage, whereas the healthy cartilage was left undisturbed. Now let's take a look at some of the human clinical data. Most of this work has been done in the area of knee osteoarthritis, with one of the first studies being done in 2017 with Hudetz et al., 17 patients with moderate to severe knee osteoarthritis received a single ultrasound-guided intra-articular MFAT injection. They interestingly used a gadolinium-enhanced MRI to evaluate the production of proteoglycans in the cartilage. They showed that the visual analog scale at rest improved almost 86% in these patients, and the glycosaminoglycan content was shown to improve in more than half of the measured areas. Dr. Panchal, Malenga, and Scheinkopf published this paper in 2018. They also looked at 17 patients, 26 knees with moderate to severe knee OA, with most of these patients grade 4 knee osteoarthritis, with a single ultrasound-guided intra-articular MFAT injection. And they followed their patients for 12 months, and they showed significant improvements in the numerical pain scale, the knee society score, as well as the functional and lower extremity scales. And most importantly, no serious adverse events were noted. In this study in 2019, 20 patients with a variety of degrees of severity, they received a single intra-articular injection of MFAT with significant improvements in KOOS. If you look at the blue line there, that's the baseline KOOS level. Of course, increasing scores are better. So you see the 5 subscales, all improving at the 12-month follow-up time point, which were statistically significant improvements, and no serious adverse events. In this study by our friend Ken Mautner and his colleagues, he looked at 76 patients with mild to severe osteoarthritis, comparing a single ultrasound-guided MFAT injection in 35 patients to 41 patients who had received a bone marrow aspirate concentrate injection, which also has demonstrated efficacy and safety in other studies. And at at least 1 year follow-up, patients showed improvement in their KOOS outcomes in both groups, as well as a reduction in the pain. There was the MFAT group was slightly older and had slightly more severe baseline pain and function, but you can see the results are comparable. In this retrospective case series with Haidari, 110 patients with knee osteoarthritis, most of them with severe knee osteoarthritis and severe baseline pain, were treated with a single ultrasound-guided MFAT injection, and 81% of those patients showed improvement in their pain scores and their Oxford knee scores at 12-month follow-up without adverse events. Our colleague and friend, Dr. Malenga, and others showed that in 20 patients with KL score 1 through 3, knee osteoarthritis and degenerative meniscus tears, MFAT could be effective. They employed a technique where, under direct ultrasound visualization, 1 to 2 mLs of MFAT was injected into the meniscus, and then an additional amount of MFAT was injected into the joint. And you see here significant improvements in pain scores and improvement in KOOS function scores out to 1 year without adverse events. I co-authored this study with Dr. Gobi and others, where we looked at 75 patients, 120 knees, with more severe osteoarthritis than had typically been studied before, in patients who were slightly older as well. All of these patients had received a single MFAT injection, and we followed them over a minimum of 2-year follow-up, with 88% of the patients showing significant improvement in their pain. You can see in those KOOS pain scores on the right there that the patients with the less severe pathology showed greater improvement and sustainability at that 24-month time point. So therefore, we are recommending early treatment for patients to improve the likelihood of good outcome. Also of interest was the fact that 91% of these patients who had been told previously that they needed a knee replacement actually were able to avoid knee replacement at that 2-year follow-up time point. And we continue to track these patients long term. Dr. Haidari and others looked at 220 patients, 344 knees, with most of them being severe, presenting to an orthopedic clinic, and after a single MFAT injection at a minimum of 2-year follow-up, showed that patients who had had a baseline Oxford knee score of less than or equal to 39 were more likely to have significantly improved quality of life. And they found that the best outcomes were in younger males with moderate disease. There was one serious adverse event, and as far as I know, this is the only serious adverse event in any of the studies that I've read. It was a case of suspected infection. The patient underwent a washout procedure, but it was negative for infection. And you can see again that age did correlate somewhat as well with their outcomes. Now, they reanalyzed the data in this study to look at the entire 418 patients who had been treated in their clinic, and they found slightly different outcomes, and that is at minimum 2-year follow-up, that there were better improvements in the women who had been treated, with 90% of them showing improvement in their visual analog scale versus only 60% of the males, and also greater improvement in function. So this was an argument for including larger data sets. In this study by Dio and others, a prospective randomized clinical trial, 50 patients were randomized to receive either 3 monthly injections of a very low platelet count, PRP, combined with hyaluronic acid injection versus a single MFAT injection. So every month these patients would get a PRP and HA injection for 3 months versus the MFAT. And both groups improved at both the 6 and 12-month time points, but the MFAT group did have better improvement in their Tegner and their Kuss symptom score at 6 months and the Tegner at 12 months. They proceeded to do a 2-year follow-up on this prospective randomized clinical trial, looking again at the 50 patients, 80 knees, in relatively mild knee arthritis, and again showed that the patients had improved by and maintained their benefits at the 2-year follow-up. In this prospective randomized clinical trial, 58 patients with a wide range of severity were treated with a single very high platelet dose PRP, greater than 11 billion platelets, or randomized to receive 8 mLs of MFAT injection. And there was a slightly higher KL grade. In the MFAT group, you can see 3 versus 2.47. The MFAT group was slightly older. Otherwise, there were no differences at baseline. And at 6 months, both groups exceeded the minimally clinically important difference for all the Kuss subscales and the visual analog scale, with no difference in the mean outcomes between the groups. So this would suggest that the treatments are equivalent. However, we have to realize that these are very early results at 6 months. We see the MFAT showing results far greater than that, and so this needs to be studied over a greater time period. Furthermore, the MFAT group had a greater response rate, 77% versus 70% in the PRP group. And then Zafagnini also performed a prospective randomized controlled trial on 118 patients who were randomized to receive a single PRP injection or MFAT injection, and they showed similar improvement at 6 and 24-month follow-up. However, in the group that had the more severe pathology, the KL3s and 4s, the MFAT group was more likely to exceed the MCID. So 75% of those patients responding versus only 35% in the PRP group. So we believe for the more severe osteoarthritis cases, the MFAT may be more appropriate than PRP. And this is consistent with other studies you've read. 4 studies on clinical data in the knee and surgical outcomes. Russo published in 2017, 30 patients who had undergone various orthopedic procedures, including ACL reconstruction, high tibial osteotomy, meniscectomy, or other arthroscopic debridement, for example. And this was treated at the same time with a single injection of MFAT. And they basically showed that at 12-month follow-up, there was good outcomes and good safety. They presented their 3-year follow-up data on these same patients, although they did not have complete follow-up with only a subset of the patients studied, but 22 of the 30 patients had maintained or improved their outcomes. And when compared to the 12-month outcomes, the 3-year outcomes were slightly improved, and you can see that in the graph there. Cantaneo et al. Studied 38 patients, mean age 54, so there's a younger group of patients with knee osteoarthritis and chondral lesions who underwent either an arthroscopic debridement or meniscectomy plus a MFAT injection at the time of surgery. And they also were able to show good efficacy improvements in KOOS and WOMAC scores, pretty substantial reduction in the WOMAC score you can see there, as well as good safety. And then in this prospective case series, patients who had been treated with open wedge high tibial osteotomy for significant varus deformity were co-treated either with or without MFAT, and they were able to show that the group that had received the MFAT had better outcomes versus a group that just had received surgery alone without the MFAT injection. And then finally, this prospective randomized controlled trial, 78 patients with severe knee osteoarthritis, randomized to receive arthroscopic debridement with or without MFAT, showing better improvement when the MFAT was combined to the surgery at 6-month follow-up. And these benefits were maintained at the greater than 2-year follow-up without any significant safety issues. So now I'd like to share with you some evidence from the Journal of Anecdotal Evidence. And what I mean by that is real-world data obtained in my clinic as well as the clinic of our colleagues who are using a national database registry. Here we are looking at 700 patients who had been treated with MFAT, hyaluronic acid, or PRP, and we're able to show significant reduction in the numeric pain rating score out to 2-year follow-up. Now you see the end results of the PRP is similar to the adipose, but if you look at the baseline characteristics of those two groups, you'll see that the PRP group had much greater proportion of patients in the mild to moderate category versus the adipose and hyaluronic acid group. Now, you don't see a lot published about MFAT in tendon tears, but I personally think this is an area that needs further study. This is, again, from our Data Biologics registry, and we're able to look at just those patients who were treated for tendinopathy, partial or full thickness tendon tears. Specifically, I chose adipose. You can see we have 122 patients in this analysis across 27 different providers, and so thank you to those of you who are participating in this data collection. And these are patients who had just received a single treatment. Their average age was 60 years of age, and you can see the severity is pretty much in the moderate to high group, with only 8% being in the high function group. And we're able to look at the desired functionality. This is a scale developed by Dr. Malenga, and we look over a 1-year timeline, and we can see that those patients are able to exceed the minimal clinically important difference at about the 1 to 2 month time point. So this is showing very good efficacy for those patients with more advanced tendon disease. These are some cases to highlight the point. This is the first patient I ever treated with a very high-grade partial thickness Achilles tendon tear. I presented this paper at a TOBI meeting about 5 or 6 years ago, and you can see the before and after images in MRI and ultrasound showing substantial improvement in the quality of the tendon, going from the dark hypoechoic region to the very hyperechoic fibular pattern. This patient went from being in a boot and crutches for a year to being able to run on the beach 3 months within treatment. This is a patient, an avid pickleball player with a very large common extensor tendon tear. There, I added adipose to her treatment. You can see significant improvement in 5 months with resolution of pain. This is a professional golfer who I treated with a full thickness supraspinatus tendon tear who declined surgery, and he was able to return to competitive golf within 2 months. And when I reevaluated him a year later with ultrasound, I saw nearly 90% resolution of the tendon tear. And then this is a professional soccer player that we treated in the clinic who had had knee pain for 2 years and was trying to resume competitive sports. And after a single MFAT injection into this very large patellar tendon tear, he was able to return to soccer within 3 months without any pain. So what does the future hold? Well, from my perspective, I think we really need these placebo-controlled clinical trials with long-term follow-up to help us once and for all prove that MFAT is effective and where it's going to be most helpful, where it's going to be less helpful. Using real-world data evidence from data registries, we can use AI to perform data analysis and identify subgroups that may be better responders. In addition, it is now available that patients can bank their adipose tissue, which can then be stored and given back to them once we obtain FDA approval for cultured cells. And let's face it, a lot of these patients are going to need repeat treatment at some point in their life. We can't continue to do lipoaspirate every time they need a new body part treated. So I think repeat treatments through cultured cells in the bank makes a lot of sense. So thank you to you for your time and interest. Thank you to my mentor, Dr. Jerry Malenga. We had a shared interest in adipose tissue. This presentation has been recorded and will be posted on the SDOMG YouTube channel, which you can access through the QR code to the left down there. And if you would like access to the scientific references and research that I quoted in this presentation, you can find that on the SDOMG website under the research section using the QR code to the right. And now I will answer some of your questions.